Dr. Lodh.
Am I
Good
audible?
evening. Yes, sir. Yes, sir. You're audible.
Okay. Okay.
Good evening, everyone, and welcome to DS Research Center's today's webinar. The topic for today's webinar discussion is closing the care gap in
Hello.
metastatic breast cancer.
Excuse me, ma'am. Ma'am, I have not gone live. 1 second. I'll raise my hand over here, then you can start. Okay.
Okay, okay. Good evening, everyone, and welcome to DS Research Center's webinar. The topic for today's webinar discussion is closing the care gap in metastatic breast cancer. I am Dr. Archana Kori, Ayurvedacharya, DS Research Center, Mumbai. The webinar will run for an hour, and we have our guest speaker for today's session, Dr. Nimesh Lod, who will educate us regarding the topic, and we'll have some time for questions in the end. Please feel free to ask your questions during the webinar. The session is being recorded and will also be available on our website. Okay, now I would like to introduce our guest speaker for today's session, Dr. Nimesh Lod. Dr. Lod is practicing breast oncosurgeon hailing from Mumbai. He brings a wealth of experience for today's session. He has worked for over 12 years of exclusive breast surgery. Dr. Lod also specializes in mammary duct endoscopy, breast oncoplasty, therapeutic mammoplasty, male breast cancers, gynecomastia, hemoport insertion, genetic counseling, and risk reduction surgeries. Dr. Nimesh Lod is presently working at AIMS Dombivli. I would now like to request Dr. Shibangi Das to proceed with the further program. Handing over to you,
Thank you,
Dr.
Dr.
Shibangi.
Archana. Thank you so much. Dr. Archana herself has an experience of a decade in medical practice, and she is associated with us for last 3 years. Uh, I really feel glad to be coming up with this discussion session because it is one of the most important topics, that is closing the care gap in metastatic breast cancer. Most of the times what we see is early detection helps better results of treatment, but in patients who have metastatic cancer or advanced cancer, they are worried about the prognosis of the disease and the fate. So we being doctors, we have an essential part in our job, that is spreading awareness regarding this disease and filling up this gap and closing it. So in today's session, we'll try to come up with a simpler understanding regarding this disease and giving up as much as possible information for this condition. So I'll start with Dr. Archana. Dr. Archana, please explain us about what is exactly breast cancer.
Thank you, Dr. Shibangi ma'am, for the question. Before defining breast cancer, I would just like to brief what is exactly cancer. Cancer begins when healthy cells change and grow out of control. These uncontrolled growth of cells form mass, which is also called as tumor. When the same process occurs in the cells of the breast tissue or in the breast cells, it is termed as breast cancer. When this process is localized in the area of the breast or the nearby lymph nodes, it is called as localized breast cancer. When these cells, these malignant breast cells or the cancerous breast cells, travel to another part of the body, which means that the breast cells spread to another part of the body. It is called as metastatic breast cancer. And the area where these cancerous cells reach is called as the area of metastasis. I hope I have answered this question correctly.
Yes, sure. And, then how to identify? What are the symptoms that help us identify this?
Okay. Before answering about the symptoms, I would like to just tell you that having an awareness of this disease is very much important. Everyone should know about breast cancer signs and symptoms because it helps in early detection. So, some of the important signs and symptoms which we can look for are as follows. Any unusual lump or swelling in any part of the breast or the underarms. It can be change in the shape or size of the breast, any form of discharge from the nipple or any part of the breast other than the breast milk, if there's any bleeding or if there is any other kind of discharge, we should always be alert that it can convert into breast cancer in the future. Then the other signs and symptoms which we can look for is change in the skin of the breast. The skin might look like an orange peel, which is also termed as dimpling of skin happens in early stages of breast cancer. The skin of the breast might show rashes, redness, itching, dryness, flakiness. It might look like the sign and symptom of eczema of the skin also. Then the nipple getting inverted, or like if any of the breast is having an inverted nipple or the nipple turned inwards, it is an important sign and symptom of breast cancer. Yeah, I think these are the important signs and symptoms which can help in early detection of breast cancer.
Okay, then if we proceed with this discussion, we are proceeding with the discussion. Uh, what will be the risk factors that we should consider in these cases?
Okay. So the risk factors of breast cancers can be categorized majorly into two parts. First is unavoidable or uncontrollable. Uh, and the second part is avoidable or which we can modify to prevent breast cancer. So starting with the first part, unavoidable or uncontrollable risk factors include first is the aging factor. uh, if we age, like if we cross an age group of like 45 or 50, we tend to have this type of cancer. Second is reproductive factors like early menarche, having periods before the age of 12, or late menopause, having menopause after the age of 55. It is also an important risk factor which can lead to breast cancer in future. Then comes higher density of the breast. If the breasts are more denser, it is also an important risk factor as far as breast cancer is considered. Then any kind of radiation therapy, especially if we do fluoroscopy X-ray radiations for treatments like lymphoma or other types of chest-related or localized chest cancers, which is also going to contribute, or it has a tendency to develop breast cancer in future. Family history. If a patient, like if anyone in their family, their mothers or their maternal aunts, or if their sisters are having this disease, breast cancer, so yes, first degree relative are at higher risk of developing this type of cancer. Genetic or hereditary mutations, it travels through the genes. So again, genetic factors contribute to the higher risk of breast cancer. The second part of risk factors include controllable or which we can slightly modify to prevent breast cancer. That is the conventional ones: limit alcohol consumption, eat like if you drink more, if the alcohol consumption is more, you tend to get breast cancer as well as other types of cancers also, like liver cancer or stomach related cancer or GI related cancer. Lack of physical activity, if you are not physically active, or if you are obese, yeah, there are chances that in future you might develop this disease or illness. Reproductive age, like if you are not having children, so yes, it is again an important risk factor which might develop this disease in future. So females who are not having pregnancies tend to have breast cancer in their late 40s or 50s. Then stress. Uh, we can avoid stress, but yes, if you are too much stressed, if you are not physically too much active, this can again contribute to development of this type of cancer. So I think I have mentioned the important risk factors of breast cancer. Over to you, Dr.
Uh,
Shubhamani.
yeah. So, as you mentioned, that there are some risk factors that can be controlled that can help us prevent this disease. So, it covers that controlling these factors will reduce down the risks of developing breast cancer. Anything additionally that you want to tell us how to reduce down the risks?
Yes, yes, definitely. So, as a female or as a healthy person, if you want to stay healthy, if you do not want to contract breast cancer, I would just like to
I
mention,
would, I
yeah,
would, I would be interested because Dr. Lodh has raised his hand. Dr. Lodh wants to add something. I understand.
Uh, I think Dr. Archana has been very comprehensive about the risk factors that she's just mentioned. But two things that I would like to add. One is something that is staring at our face, right in our face, that is urbanization. Urbanization is one of the biggest and the most significant risk factors. We can't pinpoint one particular reason for the increase in breast cancers, but I regularly see patients in their early 30s, late 20s, unmarried women with breast cancers these days. This was not the case around 10, 15 years back. That was much less. So that is one thing. The other thing is the genetic component. Even though India does have a low rate of genetic penetrance, we are seeing an increasing number of familial and genetically mutant strains of breast cancers. So, family history also is becoming more and more important these days, and younger breast cancers are becoming more common. So, one of the most important factors which I feel we simply can't quantify, but it is an important factor, is the presence of xenoestrogens. Now, that is something that is still a matter of debate and very controversial. But practical take-home point is xenoestrogens are an extra source of estrogens in our environment, and they are all around us. So they are present in foods because commercially mass-produced foods do contain some amount of those kind of estrogens. Plastics contain xenoestrogens. So one thing that we can always tell all our young girls is, avoid processed foods and avoid plastics in any and every form. So thanks.
Thank you so much, Dr. Lodh. Thank you for adding up these points because these are very common points that we come across. And yes, these are the points that will help create more awareness because I think present generation is much aware about their health. So I think that will be very fruitful for them. Thank you so much for adding. Dr. Lodh, I'll continue with the discussion with you. Can you explain us about the screening that every person or every woman can follow according to the age so that early detection is possible?
Screening is very important, and it begins with the person herself. So the first part of screening is understanding your own self. So I always tell people you should be breast aware. You should be aware of how your normal breast is, and there's something that I tell them that they should examine themselves, do self breast examination once a month, 10 to 15 days after their periods, because that is the time when the breasts are least tender and the nodularity also reduces. and that is the best time to pick up a lump. So anything which has never been there before, that is what they should keep a watch on. And there are lots of videos on how to do self breast examination. The important part is always to feel the breast with the flat of your hand. Very often people pick up the breast and it feels a little lumpy or nodular. But when you press it flat against the chest wall, if the lump disappears, then it's just your glandular tissue. So that is something that they always have to keep in mind. Nipple discharge, madam has already touched upon. So what I would like to add on is any single duct nipple discharge, which is spontaneous, which is noticed on the underclothes, which is clear, watery, greenish, blackish, or reddish, is symptomatic or pathological nipple discharge. Now, some people can have bilateral milky nipple discharge, which can be copious and which can be like milk. So there you have to rule out a central cause. We simply do a serum prolactin. If that is raised, then we look out for a pituitary micro or a macroadenoma, and the treatment goes on in that direction. But if it's a single duct nipple discharge and it's coming from a single quadrant, it's very important to know where that is happening. I mean, we have to evaluate. So the evaluation starts with just clinical examination. So once a person has picked up something like that, she should show us. So when we see such a person in the clinic, we always evaluate the nipple discharge by doing a cytology. A cytology is an OPD procedure. So we just make a few smears on the slides with these nipple discharges and send them for cytology. Along with that, we do a routine mammo and the ultrasound. And if that picks up something, then we evaluate further. So this is for nipple discharge. Now, as far as screening is concerned, as I said, self-breast examination is something that one must practice once a month, not every day, because that will really make them go crazy. And above the age of 40, at least a mammogram as a baseline with an ultrasound should be done. If that is clearly normal, then every once in say 13 to 14 months, one can repeat a mammogram. According to me, screening should include four tests. One is a mammogram with a breast ultrasound. Second is an abdomen ultrasound to look for the ovaries and the uterus. Third is a CA-125 to look for, it's a tumor marker for CA ovary. And the fourth is a pap smear. According to me, in a health check, these four tests have to be there because these are the most basic and they are the most important ones. India, unfortunately, does not have national health policy, so the patients pay for their own investigations. So we always have to pick and choose as to whom to get these tests done from. But I feel a basic mammogram should be done by everyone above the age of 40. And beyond that, then the evaluation or the follow-up depends on whether there are symptoms. So we can practice discretion. The other thing that one should always remember is after the age of 40, any new lump needs to be evaluated. So I come across a lot of young girls with multiple breast lumps, bilateral breast lumps. So very often I do nothing, masterly inactivity, but I keep a follow-up. So every 6 monthly I do an ultrasound to see if there's any change in the nature or the size of those lumps. So if all of them have been the same all throughout, we can safely observe. But if any of them changes, then that needs to be treated.
Okay. Okay. Thank you so much. Thank you. Uh, I'll ask one question to Dr. Archana here. As we were previously speaking about the how to reduce the risk factors, can you elaborate a little about how the weight and stress affects the risk in a cancer patient?
Thank you, Dr. Shibangi ma'am, for the question. I would first explain like how we can reduce the risk of breast cancer. So I mentioned that like the conventional ones, we have to limit alcohol consumption. Then the more alcohol if you drink, it tends to give you another types of cancers too, like liver cancers and gastrointestinal cancer. So if someone is drinking, drink in moderation and be health aware in order to prevent breast cancer. If you have stress, develop habits or inculcate hobbies which can be stress reliever, or stress busters. For example, you can go for a morning walk or evening walk. You can inculcate regular exercises. You can create a habit for doing regular exercises. You can practice yoga, meditation to reduce your stress levels. If you are a female, uh, see to it that you plan a pregnancy before the age of 30 in order to reduce the risk of breast cancer. And yes, if you have a baby, do breastfeed for at least 8 months to 1 year to your baby, which will help again to reduce your uh, risk of developing breast cancer. Be more physically active, uh, maintain your weight, maintain your normal BMI. If you are obese, do exercise, stay fit, and stay healthy. If you if you go to your gynec and ask for oral contraceptive pills, ask your gynec or ask your general physician or doctor the risk involved with those oral contraceptive pills also. I would request Dr. Lodes to guide us regarding these oral contraceptive pills also. Sir, can you please share your knowledge regarding this contraceptive pills also? There are certain contraceptive pills which uh, are having a tendency or which can increase the risk of developing breast cancer to females also.
Frankly speaking, oral contraceptive pills have always been a source of controversy, and you do know that it's a big industry, right? So there will always be people who will be pro contraceptives and who will be anti contraceptives. Having said that, estrogen is the main culprit because hyperestrogenism is the reason why we see more breast cancers. When we talk about fertile windows, so early menarche and late menopause, now that is again an increased or a lengthy fertile window, right? So again, there is more estrogen exposure. Similarly, oral contraceptive pills which contain high dose of estrogens are supposed to be, harmful. Having said that, there is no clear data which says that OCPs are directly related with breast cancer. But hormone replacement therapy is something that people are now avoiding because hormone replacement therapy earlier was advocated for perimenopausal symptoms to reduce the intensity of hot flushes. So those are now being used less. And unfortunately, most of our knowledge comes from the developed countries. So it's a cycle that happens. Uh, the thing is, developed countries will adopt a strategy, they will follow it, they will then assess and they will come to a conclusion that these are not to be used, and then, they will negate or they will stop doing it. So, unfortunately, we tend to ape the West, and you have to understand that our Indian population is much more different in terms of BMI. So, we have women who are shorter as compared to the average Western population. And there are lots of different factors at play. So it's very important that we Indianize our system of medicine because you see, the dosages have to be altered, and some people react differently. So side effects are an issue. All in all, oral contraceptive pills are something that I feel should definitely be discussed with a gynecologist. And especially if you have any of the risk factors, you should look for alternate modes of contraception. It's the most sensible thing to do. It's what I would do, right? And that is what I would advise everyone. As far as a known causative factor is concerned, there's still no clear data. So we are still, lacking that clarity.
Okay, so
It is
we do have little information whether the effect or not, but yes, that is a point of discussion, and maybe we'll get clarity later or gradually on that. Now, moving forward, Dr. Lod, Please brief us a little about the treatment methods present for breast cancer patients.
All right. So once you've diagnosed a patient as having breast cancer, the broad outline is whether the patient has invasive breast cancer or non-invasive cancer. Non-invasive cancer means ductal carcinoma in situ or lobular carcinoma. Now, ductal carcinoma in situ behaves a little differently. The prognosis is much better, and we can actually talk about cure rates if it is pure DCIS. Now, non-invasive carcinoma is diagnosed again on the core biopsy. Here, the mammogram is very important because non-invasive carcinomas often present with microcalcification. These are small specks of calcium deposition which are seen as specks of grains of sand on the mammogram. And the pattern of the deposition tells us whether it's a scattered DCIS or a focal DCIS. If it's a focal DCIS, it can be treated with a plain excision with a wide excision and frozen sections of the margins, and we can do sentinel lymph node assessment. That is part of breast conserving surgery. But if it is scattered DCIS, that is, there is widespread DCIS, then surgery may involve removal of the breast tissue. So you may require to do a mastectomy in this patient in spite of having non-invasive cancer. So that is one caveat there. Broadly, when you talk about cancers, there are four modalities of treatment. One is surgery, second is chemotherapy with or without targeted therapy, third is radiation, and fourth is hormone therapy. Now, if a tumor is primarily operable, so we diagnose the patient and then we stage the patient. So pre-operatively or pre-treatment staging involves a PET. A PET is a metabolic scan. So it not only tells us about uh, disease status in the body, but it also tells us about the disease uptake or the aggressiveness of the disease. So if the PET does not pick up any metastatic disease and you see just localized disease in the breast, then this patient can be primarily operable. Now, surgery has two options. One is a breast conserving surgery, and second is a mastectomy. Breast, I'm sorry. Can you just give me half a minute?
Sure. No problem.
Yes. I'm sorry, I have a very naughty 3-year-old.
You
So,
shouldn't be sorry about that.
yeah. Uh, I was talking about surgical options. So if the tumor is primarily operable, we can offer the patient the option of breast conserving surgery versus a mastectomy. Now, my patients play a very important role in the decision making because whether they want a mastectomy or whether they want a breast conservation is something I leave entirely up to them, provided it is feasible and possible to do. So if the patient is amenable to a breast conservation, I explain to them the pros and cons and then let them take an informed decision. However, it's always an attempt. So when we attempt to do a breast conservation, we always do a frozen section of the cut margins because sometimes you can have scattered DCIs in these margins and you may have to then convert this into a mastectomy. So it's always an implied consent whenever we take a consent for a breast conservation that this may be an SOS mastectomy if the frozen section margins come positive. Apart from this, whether to do a mastectomy with or without reconstruction again is discussed with the patient. As I said before, India is primarily a place where everybody pays from their own pocket or from insurance for their own treatment. So everything has to be practically discussed. All the modalities have to be discussed. So I always explain all these other modalities that we may require to do so that if they are financially constrained, then they should think about allocating their resources sensibly. Because what happens is very often people spend all their money on the surgical part and then they think the rest of the treatment is not necessary, which is not true. All the other treatment modalities are equally important, and we have to understand that the treatment has to be completed, because in spite of all this, the tumor may still come back. So we have to try our best. So as I was saying, the first part is surgical. So we can do a breast conserving surgery with or without oncoplasty. If there is more than say 10 to 15% of tissue loss, then we combine it with oncoplasty. There are different types of oncoplasties: type 1, type 2 oncoplasties, therapeutic mammoplasties, where you rotate a part of the breast. It is a sort of a local plastic approach, where you do not take tissue from elsewhere and bring it close to the breast, but you use the breast's own tissues using the blood supply and taking the local flaps along the blood supply. A mastectomy may or may not be combined with a reconstruction. You can do an immediate reconstruction or a delayed reconstruction. So after this, once the patient gets operated, patient gets a report, and they come to you with a follow-up report. So the histopath report then tells you what next to be planned. Accordingly, then we plan either whether the patient requires adjuvant chemotherapy, adjuvant radiotherapy, and adjuvant hormone therapy. So when we are looking at the biopsy report, we not only look at the tumor, but we also look at the immunohistochemistry profile. So there are four markers which we normally look for: the estrogen receptor, the progesterone receptor, the Herceptin receptor, and the Ki67 receptor. Now the estrogen and progesterone receptor is a very specific receptor for hormone therapy. So if ERPR is strongly positive, we can give hormone therapy. If HER2 or Herceptin receptor is strongly positive, we can add trastuzumab, which is a targeted form of therapy, to the chemotherapy regimen. And the Ki67 is a rough marker. It's a proliferation rate. It tells us how aggressive the tumor is. It's also called the poor man's oncotype DX. Now, why I've mentioned oncotype DX is there are some people who wish to avoid chemotherapy. Previously, we didn't have a way of predicting how these tumors would behave. But today we do. There is something called a recurrence score that we gain when we do the oncotype DX study. It's a 21 gene recurrence score that is done on the tumor sample, and the report turnaround time is around 15 to 21 days. So in 2 to 3 weeks time, we get the report. And if the recurrence score is low, such patients can actually avoid chemotherapy. In fact, we have seen that people who have been given chemotherapy in this subset actually have more side effects, and they actually have severe reactions. So they are better off without chemotherapy. Whereas a high recurrence score on the oncotype DX implies that this patient will benefit from chemotherapy and radiotherapy. As far as chemotherapy is concerned, the dosages and the standard regimens are quite standardized. So we give two broad groups of drugs: anthracycline based and Taxol based. And there are lots of regimens. So the first 4 cycles are given every 3 weeks, and the next 4 cycles with Taxols can be further subdivided into weekly regimens that make it 12 weekly cycles. Now, if the patient is strong trastuzumab positive, the receptor is strong positive, we can add trastuzumab to this chemotherapy regimen. Patients who have lymph node positive disease or poor biological profile on the histopath report will benefit from radiation. Now, radiation is given to prevent locoregional recurrence, whereas chemotherapy is given to prevent systemic recurrence. And after all this therapy is over, we then keep the patient on maintenance hormone therapy. Now, maintenance hormone therapy is again done with two broad classification of drugs. One is the selective estrogen receptor modulators like tamoxifen, and the other is the aromatase inhibitors like arimidex or letrozole. So earlier we used to have anastrozole. Nowadays we use letrozole. So I prefer to give a combination of these two over a period of 10 years. And it has been seen that the benefit of these drugs lasts beyond the duration. So if you've given it for 10 years, the benefit lasts for almost 10 to 15 years. Now, in younger patients with poor biological profile and with strong ER positive tumors, I also give them an option of endocrine blockade. So endocrine blockade can be given by giving injectable GnRH analogs every month for almost 3 to 5 years. Or if they wish for a permanent solution, then we do a laparoscopic bilateral salpingo-oophorectomy. Now, I prefer bilateral salpingo-oophorectomy for two reasons. One is it is cost effective because GnRH analogs are expensive, and if you have to give them every month for 5 years, it's quite a significant expense. The second thing is laparoscopic salpingo-oophorectomy is a sort of risk reduction surgery because patients with breast cancer tend to have a risk for ovarian cancer in their lifetime. So this procedure takes care of their ovarian cancer risk completely. And the second is it completely eliminates the production of estrogen. So the benefit is twofold. But of course, all these things are done only with proper discussion and if the patient is willing for this.
As we were discussing about ER and PR and Herceptin, what about triple negative breast cancer patients? And what will be the line of treatment for them?
So based on this IHC profile, we have 4 to 5 broad types of breast cancers. So no two breast cancers are alike. So the luminal A and luminal B are strong ERPR positive tumors. Luminal A is ERPR positive, strong ERPR positive with low Ki67 and HER2 negative. Luminal B may be HER2 positive with a intermediate Ki67. HER2 overexpressing, the third type, is HER2 positive. It may most likely be ERPR negative. And the fourth type is triple negative, that is ERPR HER2 negative. Now there is a fifth type called the quadruple negative, where we test uh, triple negative breast cancers for androgen receptors as well. There's a very small section of patients, around 15 to 20% of patients, who test positive for androgen receptors. Now, these patients, if they test positive for ARs, we give them something called bicalutamide, which is actually used for prostate cancer. But there are very few patients who actually test positive. And frankly speaking, I've come across very few. In fact, uh, as I said, 15 to 20% is the ratio. So this is the fifth type, the quadruple negative or the QNBC. Now the TNBC and the QNBC basically are slightly more aggressive because of the lack of molecular targets, because you have less modalities to treat them in. So because they are triple negative, the only thing you can give them is chemotherapy. Hormone therapy is ruled out and trastuzumab is ruled out. We also look for PIC mutations and the list goes on. So there are lots of other drugs and monoclonal antibodies to be considered. But triple negative subtypes tend to be a little more aggressive. So it's commonly seen in patients who are a little young and the tumor is more aggressive. And very often, in spite of everything that we do, they still tend to come back. So the recurrence rates are high. Paradoxically, these tumors, if the patient has been event free, say for up to 5 years, after 5 years or so, these behave better than the hormone receptor positive tumors. So that's an interesting paradox.
Thank you, Dr. Lo. Thank you for briefing us about, because these are something very new adding up to the because of the research and studies. Uh, Next, I'll move to Dr. Archana. One question that has come up, that if there is a benign cyst or fibroadenoma in breast, what are the chances that it might get converted into malignancy?
Generally, fibroadenoma are solid tumors. These are benign, okay, and the tendency of any female having fibroadenoma is much higher if she is having her period. So this occurs due to the reproductive hormones, and to detect or to diagnose any fibroadenoma, uh, We need to examine the breast wherever it is located. If it feels solid, it feels rubbery like it is firm, because it is benign, yes, treatment of fibroadenoma is monitoring the patient. If it is growing, surgical excision can be done, biopsy can be done to evaluate whether it is malignant or not. If it is malignant, yes, definitely we have to take the necessary steps to treat further. But generally, fibroadenomas are benign. All fibroadenomas do not get converted into breast cancer, but yes, benign tumors can also risk in future, like those females or those patients can have breast cancer in later part of their life.
Yeah. So here comes the role of screening and
I think Dr. Lod has
self-examination. Yes, Dr. Lodh, you have raised a hand.
May I add, when we are evaluating fibroadenomas, what I normally do in my practice is that any lump less than 3 centimeters we generally observe, and we have a baseline evaluation which tells us whether it looks like a fibroadenoma or not. The differentiation or the differential diagnosis with a fibroadenoma is a phylloid tumor. The only way to diagnose this is with a core biopsy. So any tumor, if you see if it's showing a world appearance or there are some cysts or clefts on the ultrasound film, I would ask for a core biopsy. A core biopsy will be able to tell us whether it's a benign phylloids or a borderline phylloids or a malignant phylloids. Phylloids tumors have to be excised, and the excision has to be with a wide margin of tissue because very often they tend to recur. Even benign phylloids I've seen recurring, borderline phylloids I've seen recurring. Malignant phylloids have to be treated with adjuvant radiation as well. So that is an important part of the treatment. And most fibroadenomas can be safely observed, but any fibroadenoma which is growing, especially in a young patient, I would prefer to operate, especially if we are anticipating that she's going to plan pregnancy, because sometimes during pregnancy these same lumps can increase dramatically, and then it becomes a problem operating in the second trimester because breasts are more vascular, there's more vascularity, so it becomes a problem.
So adding up to this discussion, I have one more question for Dr. Lodh. How does density of breast become a risk factor?
Because we can't pick up stuff. The increased
Because
breast density makes it difficult for us to assess very clearly. So whenever I do a mammogram, these days we do a mammogram with a tomosynthesis. It's like a CT scan of the breast. So it also helps us in evaluating these densities. But along with these, we also do an ultrasound. The most important part being in younger patients with more dense breasts, it's easier to pick up solid lumps, it's easier to pick up cystic lumps, and it is easier to pick up lumps which may cause a problem later on. The other thing is with increased breast density, if there is any suspicious finding, we add an MR here. So a breast MR is a way of looking at the breast a little differently. Mammograms look at the densities. Ultrasounds will tell us the consistency, whether this is solid consistency, whether it's fluid filled, or whether it's a complex cyst. MRI looks at vascularity. So very often what happens is before you see a malignancy, sometimes you pick up non-mass like enhancement on an MRI. What do you mean by non-mass like enhancement? It is like if you see a construction site. So before a building comes up, you will see that the construction site has been cleared. Then you see a lot of infrastructure material there. You will see the base being built. So similarly in the breast, if there's a tumor building up, you will see increased vascularity in a particular area, but there's no mass that you can pick up. So this non-mass like enhancement is very important, which is picked up on the MR. So MR has a different role. Also for symptomatic nipple discharge, we always do an MR because that picks up the intraductal lesions, because most symptomatic nipple discharges we pick up papillomas after surgery. So the pathological specimen generally picks up a papilloma or multiple papillomas, which are most often non-cancerous, but they have field changes. So there are changes occurring around that papilloma. So that is very important. So this again is picked up in the MR.
Dr. Lod, there is one question very important that we have come up with, and it is very important to understand that uh, how the family member can support a breast cancer patient while she is undergoing treatment. What are the things they can do from their end to help her out?
Very important and very significant. Don't make them feel alienated. They have to be part of your family, and they don't have to be isolated from the family, because this is not a communicable disease. Very often people do ask me this practical question, that can we live in the same room, can we share the same bed, can we eat in the same plate. It's not communicable, so that is something that they have to understand. And family therapy plays a big role. It's family therapy, because the entire family gets affected when you have breast cancer, right? It's not just the one person alone. So the entire family needs to rally around that person. That is one. Secondly, as far as physiotherapy is concerned, a person doesn't have to go to a physiotherapist every time. A person is more likely to do better if there's a family member egging her on to do her routine or to do her routine exercises. So these are some things that family members can definitely play an active role. I always advise patients during chemotherapy to eat home cooked food, and I do not advise them to take protein supplements or to take special multivitamins, because what you eat at home is more than enough most of the time. But it has to be cooked and it has to be freshly eaten. All these things can be really, really helped up by the family. They require
Thank
empathy, not sympathy. That is important.
Thank you, Dr. Lod. Dr. Archana, would you like to add something to this?
Following mastectomy, there are many complications. For example, there might be edema of the operated side, there might be edema uh, in the upper limbs, there might be pain post surgery also. So, all these things need to be managed well, and the family should support these patients. And yeah, I think that's enough from my side.
Uh, I think uh, we have been coming up with these questions from patients and from the relatives of the patient, and we do face all these questions. And I think today's session might have helped many people to understand what exactly it is and how they can help from their end. And doctors are always approachable. You can go up and speak to the doctor, because as much as clarity we get for this disease, as much as information we get about this disease, we are more prepared to fight it back. And these seminar or webinars discussions do help, and I wish it keeps on helping our patients. And thank you so much, Dr. Lod, for coming up and giving us so
My
much
pleasure.
of information. Thank you so much. Thank you, Dr. Archana. Thank you
Okay.
so much.
Thank
Thank
you.
you, Dr. Lowe. It was good to have you for the session today.
Thank you,
It
ma'am.
was really a good.
Thank you, ma'am.
Thank you.
Okay. Bye bye.
Bye bye.
Bye, sir. Good day.
You too.